talking about PVCs. Remember, they're irritable ventricular cells. So they're always going to be irritable. Like we also said this, they fire once, or they might be rapid series, couplets, or runs of PVCs. A run of 3 or more PVCs, again, we call ventricular tachycardia. If this run of ventricular tachycardia lasts longer than 30 seconds, we give it a term called sustained ventricular tachycardia. And when we have sustained ventricular tachycardia, that person is likely not going to be feeling well. Because if you remember, with one PVC, right, that was 80% of stroke volume blood, right? The second PVC, or a couplet, was 58%. We also discussed that mitral valve prolapse was one of the reasons why somebody might have more frequent PVCs. It's also called Barlow's syndrome, a little bit more prevalent in females compared to males, with specific types of body shapes. The RNT phenomenon was briefly discussed in the last PowerPoint, where if you have a PVC that lands on a T wave, so this is what we call the RNT phenomenon, and if that does happen, you're actually a little bit more susceptible for other dangerous rhythms to occur, because this is a vulnerable period of the ventricles, because the Purkinje fibers are still repolarizing, right? Because that's what the T wave is, right? Ventricular repolarization. And that T wave is still that rapid phase. However, during this time, those Purkinje fibers are not ready to fire again. So if a PVC lands and an angry ventricular cell stimulates while still repolarizing the other portion of the ventricles, it can lead to other arrhythmias. So here's where you see that you have a PVC land, your R wave lands on your T wave, and it created a couplet. Okay, you have a single beat, and your R on T occurs right here, and then you have 1, 2, 3, 4 beats. Right, you see these wide beats, right? If they're wide, that means they're originating from the ventricles. 4 beats of ventricular tachycardia. Okay. Here are some examples of your bigeminies and trigeminies. Here's ventricular bigeminy, better than my drawings. And here's ventricular trigeminy. Some new rhythms that we're going to learn are your other tachycardic rhythms. These are dangerous rhythms as well. These are part of our potentially deadly rhythms. Our paroxysmal ones are less dangerous than our flutters or fibrillations when it comes to ventricular, but still can lead if they are sustained for longer than 30 seconds. If they are sustained, they put you at higher risk for entering or converting into these other rhythms. So this term paroxysmal refers to or translates to sudden onset. Sudden onset. So you can have a sudden onset. So that's just a way we describe specific types of rhythms and how they originate. You can have a sudden onset of tachycardia. It could be a paroxysmal, which I'll just abbreviate here with a P, with paroxysmal atrial tachycardia. Atrial tachycardia. And paroxysmal atrial tachycardia would be, think of something like multifocal atrial tachycardia, right? MAT, where you have multiple cells, right? So if that happens, what we do is we just call it PAT. All right, that'll be similar. A sudden onset of atrial tachycardia. It's not going to be from the sinus node. It might be from one single cell, or it could be PMAT, right? The word paroxysmal just means a sudden onset. So it might look like this. PQRST, PQRST, and then you all of a sudden you have PQRST, PQRST. Okay. And it might look like it might be like atrial flutter or something like that, but your P waves and T waves will be a little bit more distinguishable because in atrial flutter, remember, we have this sawtooth look. So we had nice normal P waves here, P, P, and then also all of a sudden these were P primes, P prime, P prime, P prime, P prime. So here we went from sinus rhythm, right, to paroxysmal, paroxysmal atrial tachycardia. Okay. If all of these P waves were a little bit different, so maybe I had some P waves that were, this way, and all different types of P primes. So maybe I have a P prime prime, P prime prime prime. Now I have paroxysmal multifocal atrial tachycardia. So I have a bunch of different things. So typically when we have these paroxysmal rhythms, they're at a high rate. They're really high, starting somewhere around 150. Sometimes they can go as low as like the 140s, okay? But typically 150 is around where these paroxysmals or these sudden onset of tachycardias occur at. Now, when we talk about our flutters and fibrillations, they range from 250 to 350 and 350 to 450. So as you can see here, we have kind of an order in which these rates occur. Your tachycardias are fast, then your flutters are a little faster, and then your fibrillations are the fastest. So here we're going to follow, I'll outline this because it's really difficult to see. I'll give it a little bit darker. Maybe not black. Maybe blue. There we go. So I had to concentrate really good here just to outline that. So here we have paroxysmal ventricular tachycardia. So again, this word paroxysmal just means sudden onset. So this means sudden onset of ventricular tachycardia. And remember, we just talked about ventricular tachycardia, meaning that means we have 3 or more PVCs in a row. So we have 3 or more PVCs in a row. Well, where are PVCs? Well, here's a PVC right here. Here's a PVC, 2, 3, 4, 5 PVCs. 5 PVCs in a row. That's pretty dangerous. Now it started from here, some sinus beat, some sinus rhythm. I don't know, is this sinus Brady's, normal sinus? Looks like it's normal sinus. I got 1, 2, 3, that's 5 is 8. right, 13, 14, 15, 16, 17 boxes here. 17 boxes into 1500. Do some quick math. Looks like we're going to be in the 90s. Nope, 88 beats per minute. So we have normal sinus rhythm, 88 BPM, 2, or then just do a little arrow like that. Paroxysmal, so go P, V, tach. Do paroxysmal ventricular tachycardia. And now with ventricular tachycardia, it's typically regular as well. So we could take a quick peek at that right now. And let's see if it is. Let's change this to a purple, maybe that might show in contrast. Let's make this line a little thicker. That way it's a little easier to grab onto and see. So it lines up pretty good there. And that lines up pretty good there too. And this one looks like it changed a little bit. Yeah, that one's a little bit off. So maybe a different cell started firing here, because now the timing's off a bit. Yep. However, I know it's still going to be ventricular tachycardia because I'm going to erase these circles. I'm going to erase these circles here. I know it's ventricular tachycardia still because our QRS complex is still wide. So let's do another box really quick. Here's what 3 boxes is going to look like from there to there. Okay, so we'll have a wide and bizarre still look. So here's the beginning of your QRS complex. Definitely still wide. Okay, the end of that PVC is over here. Go to the next one. There's the beginning of it. End of the PVC is over here. Oops. Let's mark the PVCs first. And then we'll measure. So it's a wide QRS complex. So when you have a wide QRS complex, that means it's coming from the ventricles. So anytime you have a wide QRS, think ventricular. And if it's fast like this, right, because this is only 5 boxes long, guess what rate that is? If we did the 300 method, that first 5 boxes, that's 300. So right now we're looking at a ventricular beat, a rate of around 300 beats per minute. So paroxysmal V tach, 300 BPM. So next we'll talk about this supraventricular tachycardia, supraventricular. Well, when we break that term down, supra means above, ventricles. So above the ventricles, what's above the ventricles? Atrial or junctional foci. So that means we have an atrial or junctional foci. And if it's above the ventricles, right? Here's your AV node, your SA node. Okay, your bundle of His is here. And then your bundle branches. Okay, so if we have a signal that comes from above the ventricles, doesn't matter if it comes from here or down here, it's going to travel through the bundle of His, and then it's going to split. So when it splits like this, whenever it comes from above the ventricles, right? Remember our arrows, they go like this. And we said that this is less time. That means these ventricles are depolarizing at the same time, which ultimately means we are going to have a normal QRS interval. QRS normal, so interval less than 0.12 seconds. And you may or may not have a P wave. It's going to be going fast. This is going to be one of those that's going to be around 140 to 150 beats per minute. So you might not see a P wave, but if you have a normal QRS, the easy way to do it is just call it this general term, supraventricular tachycardia. So it'll look like this. And in this portion here, you think that this might be the P wave, but that is not the P wave. That's not the P wave. Not P wave. All right, so if I were to decompress this and make it expanded a little bit, if I have a QRS complex, I have a T wave, okay, and then instead of going into the P wave, it looks like it goes straight back into the QRS complex. As opposed to being something with a P wave, which might look like this. So we call this and abbreviate it with SVT. SVT. So now we have the paroxysmal. All right, this happens very often, especially in cardiac patients where they may or may not be very healthy, but it can happen, especially after a heart attack, as that heart is still kind of recovering a little bit. I see this quite frequently, where you have this paroxysmal supraventricular tachycardia. It doesn't happen for super long times, and if it does, um, you know, we'll definitely contact doctors and send the patient over to the hospital if needed. So fairly often it can happen in sick people, but also in our normal people too. But your heart can be agitated, right? We talked about irritable cells, which might fire at random times, one time. But if it's sustained and it creates this fast rhythm, that's when we call it paroxysmal supraventricular tachycardia, if we have a narrow QRS and no visible P wave. Things like alcohol and caffeine, which stimulate the sympathetic nervous system, can be contributing factors to this rhythm. A lot of times doctors try this technique called carotid massage, which I've seen a doctor try this 2 times unsuccessfully. Sometimes, most of the times it doesn't work and patients need to be sent to the hospital for some drug administration. So here's the location. You have them turn their head, right? You push on the carotid artery a little bit. This will activate the vagus nerve, and the vagus nerve should lower heart rate when stimulated. However, what can also happen is this person could pass out. Torsades de Pontis. This is a very rapid ventricular rhythm. This is also a form of ventricular tachycardia. Okay, this happens when individuals with low potassium, you'll see them congenital or birth defects, but you might see burst up to 250 to 350 beats per minute. But torsades will have a very distinct looking shape to it instead of the classic, VTAC. Where you have sharp spikes like this. Torsades is different. In classic VTAC, they're all equal height, pretty much. But in torsades, it looks something like this. A little bit smoother. And then it kind of changes. The height and amplitude are switching back and forth. So you have this kind of smooth roller coaster going on. I like to think about it like the helix or an hourglass. Okay. I tell students a good way to identify whether you have torsades or not is, rotate your EKG, clockwise or counterclockwise. That way you see it this way to see what's happening. What's happening here in torsades, you have two different ventricular foci that are competing to pace the heart in this ventricular tachycardic fashion. So that's why you have these different amplitudes and shapes of your ventricular tachycardia, and it has and follows this smooth pattern, like a radio wave. The next one we'll talk about is ventricular flutter. Ventricular flutter, you have one single ventricular automaticity cell, and it fires again 250 to 350. You have a smooth sine pattern. And this one kind of, again, looking like radio waves, but they're all of the same amplitude. The difference between this here and ventricular tachycardia, VTAC is sharper. Okay, so you're typically going to see VTAC pretty sharp like this. Flutter is a little bit more rounded at the top and at the bottom. And one of your last rhythms is ventricular fibrillation. And ventricular fibrillation is pretty much what we call sudden cardiac death. If somebody goes into sudden cardiac death or cardiac arrest, likely they go into ventricular fibrillation. If somebody goes into flutter, the next stage or the next step in the arrhythmia algorithm is ventricular fibrillation, and if not addressed, asystole. So you see this in people that are dying. Like I said, sudden cardiac death. You have no identifiable QRS complex. So similar to atrial fibrillation, where you had multiple cells in the atrium trying to fire, but not one firing completely, same thing is happening here in ventricular fibrillation, which is why we call it a bag of worms. Each cell in the ventricles is trying to fire, but none of them fire completely, right? So the heart at this point is kind of quivering. So it's kind of just shaking. Think about if you've ever been really, really cold and gotten the chills to the point where you cannot control yourself from shaking and trying to warm yourself up. That's what's happening to the heart with a visual standpoint. So here's ventricular tachycardia. Like I said, they're going to be PVCs and they're going to be a little bit more sharp. Okay. And here's ventricular fibrillation. You have no distinguishable QRS complexes, everything. This is like that bag of worms that we're talking about. Okay. You have no complete depolarization of the ventricles. And if you have no ventricular depolarization, that means blood is not going to be ejected out of the ventricles or out of the heart in general. And finally, your last rhythm is going to be asystole. Asystole. This is your flat line. Oops. Flat line. Here you have no electrical activity. Okay. So VTach, VFlutter, VFib. Sharp identifiable PVCs. All right, this is our smooth sound waves. That's flutter. This is our bag of worms. Bag o' worms. That's not an acceptable answer on the test, by the way. All right, so then defibrillators. Well, defibrillators are going to detect ventricular fibrillation most times. A lot of the ones in the hospital too can provide the shock, hopefully to start a rhythm, especially if somebody's in asystole. But typically speaking, an AED, it's an automatic external defibrillator, small portable unit. You see them all over the gyms, you see them on campuses, and actually nowadays you see them implanted in individuals' chests. All right, so if somebody were to convert into one of these bad rhythms, like VTach or VFib or asystole, and a depending on the type of machine you have, if it's a cardioverter, you can shock that person out of a specific rhythm, or you can restart their heart, especially if they go into asystole or if they go into ventricular fibrillation. The idea is because they are in like ventricular fibrillation and they have no complex, the defibrillator will stop their heart and hopefully reset it so that it gets back into sinus rhythm or any other rhythm besides ventricular fibrillation, which will allow circulation to resume throughout the body. Because remember, in VFib, you have no QRS complex, meaning you have no ventricular contraction. So if you can even get them back into VTach or VFlutter, at least blood will be circulating because each one of these in VTach and VFlutter are still ventricular contractions. But once you get to VFib and asystole, we are in a lot more trouble. Okay. A lot of times you're going to see these implanted in individuals' chests, in those that have reduced cardiac output to the point where their ejection fraction or the ability of their heart to pump has weakened severely. And that can be they can be more susceptible to sudden cardiac death. So what can happen is, say an individual suddenly goes into VFib, an AICD, automated implantable cardioverter defibrillator, will fire, and it will hopefully reset their heart back into a sinus rhythm. So here's your AICD right here. It'll detect VFib, and then it'll fire if it detects that rhythm. Last thing we're going to talk about is Wolff-Parkinson-White syndrome. We abbreviate it with WPW, and WPW is a congenital disease most time, typically higher prevalence in the African American community. I actually have a personal friend that has WPW, and he had no idea until he went in for some complete other surgery, and they did an EKG, and they found out that he had WPW. Now, what WPW does and what makes it a little bit dangerous is we have this accessory pathway that can conduct down to the ventricles. So think about it as a shortcut. So remember, after the sinus node fires and the atrium depolarize, we have this embedded pause at the AV node. And that pause at the AV node is important because it allows blood to move from the atrium into the ventricles. However, if you have Wolff-Parkinson-White syndrome, you have this accessory pathway that short circuits the AV node. It's called the bundle of Kent. So that bundle of Kent, instead of allowing the wave of depolarization to pause at the AV node, the bundle of Kent is wide open. So once it depolarizes, instead of going here, it'll go through here and then down to the bundle of His, and then the bundle branches and Purkinje fibers. So this short circuit at the AV node prematurely depolarizes a portion of the ventricles. Okay. And what we'll see is this delta wave. And this becomes dangerous because blood has not moved completely from the atrium down into the ventricles. So here's that delta wave right here. So instead of having this pause in conduction and then a QRS complex, it went straight following the P wave. It went straight into a QRS complex. So there's your delta wave. So our delta is Greek for change, right? And we see it as a triangle. So you kind of draw a little line there and you have yourself a delta wave. All right, everybody. So that's the end of chapter 5. This wraps up everything that we're going to cover before our first exam. I'll be posting this video, making it available to you via Blackboard. And over the next week and a half, we'll be reviewing strips and answering questions as needed. All right, everyone, take care.